Hello, welcome to week two. Again, I'm going to do a brief overview of information from the three chapters that we were to talk about this week. Uh, the first one talks about uh, substance misuse with co-occurring mental disabilities, health disabilities. And there are a lot of co-occurring disorders. A lot of times you will find somebody who is uh, dealing with a substance use disorder. And there are times when perhaps that started because they found a chemical that eased some of their uh, underlying psychological issues that they may not have been aware that they had. Uh, Other times, perhaps the use of substances has then upset the balance of the brain, the chemical balance of the brain, and that then leads to a co-occurring mental disorder. The fact of the matter is that we'll probably find that many people do have multiple diagnoses, sometimes perhaps misdiagnosed. I remember when I first started working in the addiction field, I worked with adolescents. And I looked at the charts and I realized that maybe 70% of the kids I was working with had been diagnosed as having bipolar disorder. And I felt that was a little strange. And later went to a workshop where they told us how rare bipolar disorder is. And then I realized that what probably happened was that the child was exhibiting some rather some mood swings. The parents take them to the doctor. The doctor says, "Are you doing drugs?" The kid says, "Oh, no." So the doctor says, "Okay, well, it must be a bipolar disorder." But the fact of the matter is, if your kid is taking drugs and is not having mood swings, he's probably getting ripped off by his dealer. So, but if the diagnosing doctor does not know about the drug use, they're going to misdiagnose. So, that can be a problem, but they do indeed uh, coexist. And the book brings a mention to a few common. Anxiety is one, and again, people who have anxiety issues will often find a depressant drug eases those feelings of anxiety temporarily, but of course the problem is that the drug wears off and the person then is once more anxious. Uh, Obviously, post traumatic stress disorder often co-occurs because people find that they do get some relief from the the trauma when they are able to medicate it away. Bipolar disorders, depressive disorders, schizophrenia. So I think the chart on page 169 gives a really nice view. It's the quadrant of care model, and it shows the people who are in category one who have a low severity of alcohol or substance use disorders and mental illness. The mental disorders are less severe, and a primary care setting is probably fine. All that person really needs is some type of brief intervention to get them back on track. In category two, where the substance use disorder is in low severity, but the mental health disorder is in high severity, uh, you want to get the person into the mental health system, where their primary care would be involving the mental health issue, uh, probably with some help in dealing with the substance use disorder. If you get to category 3, where there's a high severity of substance use disorder and a low severity of mental health disorder, uh, then you want to get that person into the substance use system, seeing an addiction specialist, perhaps going into some type of treatment program to help them to get that dealt with. The category 4 is the most difficult, where people have both high severity substance use disorder and mental health disorder. And there, the care is going to be more likely in state hospitals, jails, prisons, emergency rooms, because these people are going to present problems that either get them incarcerated or their mental health disorder is so severe that they are deemed perhaps a danger to themselves or others. Uh, the ideal way to treat disorders like that is with integrated care. Uh, Many inpatient programs now find themselves dealing primarily with dually diagnosed people, mainly because your problem needs to be that severe before you get into a program, because you have to prove medical necessity. The difficulty is that most programs either specialize in mental health or they specialize in substance use disorder. And even though some programs will say that they are dual diagnosis, uh, they really are geared towards treating one or the other. There is more of a movement now towards true dual diagnosis programs, and those would have both mental health and substance use disorder clinicians on staff and available to work as a united team to help the person. So those are some of the high points of chapter 4. Chapter 5 starts talking about gambling, eating disorder, shopping, and other behavioral addictions, or as they're often called, process addictions. And in that group, gambling disorder is unique in that, first of all, it is a DSM 5 diagnosis and has been in the DSM 5 placed in with the addictive disorders, whereas it used to be under obsessive compulsive. Uh, Gambling disorder is a very real thing. I know here in Massachusetts, there was a lot of concern that when the casinos opened, that there would be this great increase in gambling. And there certainly has been an increased focus on providing treatment for gambling. But the fact of the matter is that it's the scratch tickets that are probably the crack cocaine of gambling addiction. And I have worked with people who have probably come close to ruining their lives with gambling addiction. I worked with one gentleman who had power of attorney over his father's um savings. He not only went through his own savings, but he went through his father's savings on scratch tickets. Worked with another guy who was using all of his money, his pay, to buy scratch tickets and began, as he put it, borrowing his fiance's debit card to buy gas and lunches, and couldn't quite understand why she was upset and why she would say that he was stealing from her when she found out. So, gambling disorder uh, often coincides with substance use disorders, particularly with alcohol. Uh, and if you think about it, if you've ever been to a casino, a lot of times they are providing free drinks. Obviously, if you have a few drinks, you're going to be less cautious of how much money you're spending gambling. Another big problem with gambling disorder uh, is a high suicide rate. When people's gambling catch up to them, when their world starts to fall apart and they are no longer able to hide what they're doing from their family, often suicide seems like an easy way out, uh, which then leaves the family with not only dealing with probably the loss of their house, having their whole foundation crumble, but now they're also dealing with the loss of a person who, at that time, they're not exactly feeling that much affection for. It really can be difficult. The book also points out that internet gambling is more of a problem, uh, and it certainly is a growing situation. Uh, for any of these, the book talks about motivational and cognitive therapies. These are very important in the treatment of all addictions, actually. So I want to keep that in mind. The book talks some about things like shopping or spending addiction. This is not in the DSM. It is not a recognized disorder, but very common. And again, the internet makes it even easier because even if you can't leave the house, uh, we've been in lockdown uh, pretty much from the COVID-19. A lot of stores have been closed, but you could order online. And, you know, probably as guilty of that as anyone. So when you're talking about shopping, the question becomes when does it go from an activity to a disorder? And the short answer is when it starts interfering with the quality of the person's life, when they are spending money they don't have, when they are beginning to hide their shopping from other people, when they are beginning to buy things that they don't really want or need, when they have things, that they bring home and never even make it out of the bag. Uh, and particularly, when it prevents them from being able to do the other things in life that they need to do. On page 228, they start talking about being lost in cyberspace. And this is a growing problem. This is one that is likely to make it into the DSM with the next revision. Uh, and, you know, the, the internet is one of those double-edged swords. Uh, my wife and I used to, we'd have a question about something, and she had a set of encyclopedias. Uh, it shows how old school we were. And we would open up the encyclopedia and look up whatever it was that interested us. And we would find ourselves kind of looking, either something in that article would take us to another article, or, we would just kind of flip around the pages nearby and get into other things. But now with Google, it is so easy to fall into a rabbit hole and get pulled deeper and deeper into things. And of course, social media uh, has not made it easy. It with social media, there's always that worry you're going to miss something. I sometimes would teach uh, the HSB SOC 208 substance abuse class. In that class, we have students give up an activity or a substance, something like sugar, salt, for 2 weeks. A lot of times, students would choose social media or video games as something to give up for 2 weeks. And we're often amazed to find how difficult it was to stay away for 2 weeks from social media. People began to realize just how routinely they would check their phones for Facebook updates or whatever Twitter. I think we could all probably diagnose somebody who spends too much time on Twitter. So it certainly is out there. The chapter goes on again to talk about cognitive therapy and the strengths perspective. We're going to get into talking about motivational enhancement and cognitive therapy more, I think, probably next week. Um, so that's a good thing to look at. Uh, the chapter also talks about eating disorders. To me, it's very important to recognize that as addiction counselors, we are not really qualified to deal with eating disorders. Yes, there is an addictive quality to it, but it is really a much more advanced problem that people with far more specialized education really should deal with. So that takes us to chapter 6, which talks about addiction across the lifespan. And usually, when I do the lecture on this chapter, I talk about how when I first started doing treatment, we had two groups of people in any treatment program. There was the adolescent program and the adult program. Adolescent ran from about age 12 to 17. The adult program was ages 18 and up. And if you worked in a program and you had somebody who was 17, and my first job was an inpatient program, and we would have somebody in our inpatient program who was 17, and if their birthday occurred while they were in treatment, the minute they hit age 18, we legally had to transfer them into the adult program. The problem is that the average adult age was probably 30s or 40s. So this person would not really have much in common with the people that they were now in treatment with. More recently, they've started, uh, sometimes it's called transitional age youth, which is about age 18 to 25 or 26. And people in that age group still have some adolescent qualities. Their their concerns are generally not yet where adult concerns are, where they have jobs and family and all these types of things. Uh, and even when we start talking about adults, uh, age 18 up is quite a large spread. And there are seniors, And more people are starting to look at senior treatment, which can have very different issues. Because, with adolescence, you are looking at becoming yourself and a part of society less than as being part of your family and part of your parents. At 65, as you're getting into the senior years, you are moving away from a life of work. You're moving into retirement. Your world changes now in a society where you're identified by what you do. You start to lose some of that identity. Chances are you're also starting to lose friends as people begin to age and pass away. Uh, so, the main point, I think, to take away from this chapter is that at different ages, people's needs, their issues, their whole focus changes. And we need to change our treatment to meet them at that stage of life that we're at. And it goes back to what I've said before, fitting the treatment to the person rather than trying to fit the person to the treatment. So I think that we really need to recognize what life stages this person at, what issues are they particularly dealing with, and take it from there. So that's a very brief overview of the three chapters for the week. Again, uh, there is the discussion question. I did break the class into three groups so that you can do your, uh, perhaps have some interplay. You are not required to respond to other people, but if you want to have conversations, I do encourage it. It just is not something that is required for grading. Uh, because sometimes you just have nothing to add. And I don't believe in forcing people to add something just because we think you should interact. Also, want to point out that there are two Zoom meetups scheduled for Wednesday. I believe that's June 10th. One at 11 in the morning and one at 7:30 in the evening. If you go to well, if you're watching this, you're on the Moodle page. So if you look below where this video is, you'll see two links. One is the invitation to the AM meetup, and the other is the invitation to the PM meetup. And if you can make one or both of those, I look forward to it. And we'll talk to you later. And I hope things are continuing to go well for you. Talk to you later.